Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
So welcome everyone to this episode of Thinking Thoracic. I'm Keshava at Thoracic Surgery at the University of California, Irvine. And I'm here today with Dr. Sid Murthy, who is a section head at the Cleveland Clinic in thoracic surgery. So welcome, Dr. Murthy, and thank you for joining us.
Hi, Hari. It's good to see you again. I knew you when you were a much younger surgeon, and you're doing terrific. Congratulations.
Well, thank you very much. And it's really excited to talk to you. And today's episode, we're actually going to be focusing on something that we all face, which are these kind of pulmonary and lung surgery disasters, both in the operating room as well as post-op. And it's going to be great to kind of have your insights.
I hope I'm not selected for this because I'm famous in causing such disasters. Hopefully I'm okay because I can correct such disasters.
Yeah, no, and it's you have a wealth of knowledge that I think you can share to all of us in the general thoracic community. So this is kind of really exciting. So with that, I just want to talk about the first scenario. The first one that kind of many of us have faced are if you have a patient, let's say a 65-year-old gentleman who you did a lobectomy for lung cancer, thought it was an early stage, about 4 centimeter, kind of close central. Initially, the margins were negative on your frozens, but now your pathologist has given you a call post-op and is saying, hey, I think you have a positive vascular margin. Kind of, how do you approach that? What is your thought process behind that, and how do you move forward?
Yeah, that is it's a difficult problem for any of us, and that does happen occasionally. One of the problems with the margins we get on lung cancer operations is that most of us are stapling the tissues. And it's not surprising that when you staple the tissues, the margin you get from the pathologist is probably not the true margin because they have to cut the staple line out. And depending on how savvy your pathology team is, if they cut back too far to get the staples out, because you can't put them through a microtome or anything like that, suddenly now they may be into the tumor. We see this all the time in, let's say, a sublobar resection, and you're doing a wedge resection, and it's fairly deep margin, and it's not on the spine of the lung where you have a fissure to help reduce the distances between the two edges of your stapler. So your stapler, let's say it's on the convexity of the lung, and you have a lot of tissue in there, and you're firing, let's say, heavy wire staplers. And that specimen, you'll notice it'll retain air. It's usually a pretty big specimen. You pull it out through your port and then send it out to pathology, and they cut the staple line. Suddenly, the tissue inside springs forward, including the potential nodule. So that's a classic issue where the margin you are getting may not truly be the actual margin. So the vascular issue is also certainly problematic for this, as is the bronchial margin, not just the lung parenchymal margin. So I think that you have to understand whether you would be expecting a positive margin. So you have to know where the tumor is, and when you're looking at it, whether you're doing it with a minimally invasive platform or you're doing an open thoracotomy, you really that you don't get a second chance to make a first impression on a lot of these things. And if
Hmm.
you are expecting a really tight margin, then some consideration of a preventative strategy might be indicated, which might be, if you're minimally invasive, opening, doing an arterioplasty, doing something else, or even doing that on a minimally invasive platform if you have that skill set. But something to anticipate a tight margin. Now,
Hmm.
the advantage of a clamp and cut technique on a vascular margin is that the pathology team doesn't have a staple line to deal with. They are actually looking at close to your true margin, right? I mean, that would be it. So if you are expecting something really close, you really have to be careful so you don't put yourself unknowingly into that situation. So that takes
Yeah.
the judgment. You got to look at the scans, understand, know where your hot spots are in terms of potential margin issues. Um, because if you get one back in the scenario you just presented, you're not sure whether it was a true margin. If it is a tumor, let's say that it wasn't right on top of a pulmonary artery branch or the vein, and you're getting a positive margin, there may be something about a quirk in the processing. If
Hmm.
when you were looking at it, there was nothing there, you were well away from it, the tissues were compliant, there was no desmoplasia, etc., to really make you concerned that there was a margin. I'm not sure how many people actually get vascular margins on most specimens they send anyway, unless
Hmm.
you're really nervous. And if you're nervous about it, I would say that the conduct of the operation may need to be adjusted to avoid this kind of situation. Because if you get a positive margin, then the dilemma you bring up
Hmm.
is a dilemma because there's no real answer. You're not sure whether it was a a, um, a bogus margin, and if it is a positive margin and you've cut way back already, many people, if they've done this on a robot or VATS or whatever, there's a certain amount of momentum or inertia that needs to be generated for you to go back. This is after the fact now, because you had presumably a
Correct.
negative margin in and do something. Many people would say you watch the margins, you're not sure, you have a low threshold for port postoperative radiotherapy, but you don't do that right away. You've got to wait for there to be a recurrence. If it is
Yeah.
a young person, aggressive tumor, and you really believe the margin, I'm not really sure you can leave it. I think that as soon as you hear it, you probably need to act, honestly. If it's someone who was marginal when you got them
Hmm.
through, I think there might be some wiggle room in convincing yourself that you could watch this. But if the person has pretty reasonable pulmonary function and it was a high grade tumor, and you really need to get negative margins. I don't think there's
Yeah.
anything better than a surgical negative margin. I don't think a positive margin with radiation would even be in the same stratosphere in terms of efficacy of treatment when compared to a negative surgical margin.
Yeah. I think that's the dilemma is, do you go back or do you give post-op radiation therapy? And I agree. I think going back makes sense, but it can be hard when you're sitting there with the patient or if they have marginal pulmonary function tests
Yeah, I think
in that situation.
if it's a marginal pulmonary function, you can talk your way out of that because the morbidity of reexploration. If you're way back on the margin and now you're doing an arterioplasty, it's not really a lung issue, but it's a
Hmm.
more complex operation, and it certainly is challenging. You have to remember about the radiation though, that this is central radiation here, right? This
Yep.
is not peripheral radiation. So you're talking about 6,000 rads centrally. Fine, it'll be fine for 3 months, 6 months. But if you start getting some radiation fibrosis, traction, bronchiectasis, then you're heading down a pathway that is not quite as innocent as you would think. Now, the other thing that does come into play here is we're in the era of immunotherapy, and
Hmm.
some of these other things we don't know the answer. We think we have an answer on postoperative radiotherapy. There's very few indications. Honestly, almost every study we've kind of looked at really can't demonstrate a real benefit. The positive margin may be one of those things that, okay, you can argue for it, but as for anything else, it's a hard sell, perhaps because of late morbidity. But immunotherapy in a setting
Hmm.
like this, if they weren't induced before, or if they have a high PD-L1, so there's going to be some change, I think, in maybe the way we think about this and a positive margin. If you can't re-resect it for whatever reason,
Yep.
you get any benefit from someone who happened to have a very high PDL1 and a very sensitive tumor to that strategy. Those are unanswered questions. I'm not sure I'd want to hang my hat on that being the answer.
Yeah.
I think I would err on the old school. Just try to take it out if you can. If you're comfortable that the margin being read as positive was reasonable, that the tumor
Yep.
was right there. And if that's the case, then I would have argued that you should have thought about the possibility of a positive margin on the pulmonary artery and considered arterioplasty at the time of the operation. If you knew it was a really close margin and a really high risk margin, I think you have to think about some of those things up front.
Thank you very much, Dr. Murthy. That was a phenomenal response to all of this type of rough scenario. I'm going to change it up a little bit, kind of along the lines with radiation therapy. Let's say you have a patient who had a metastatic colon cancer met that was central and got radiated, and now is seeing you because you're worried about an empyema. And when you look at the CT scan, you're worried that the lung is not fully expanding to take up the whole chest cavity. And of course, it looks infected after you place a chest tube. How's your thought process with that? And what do you do about that?
Okay, so this is impossible scenario number two. So you're presenting an issue that is complicated by another issue that prevents you from really doing the standard treatment for an empyema. So the
Hmm.
issue you're presenting is radiotherapy, and you may have a loss of compliance of the lung. Your lung may not be now, once it separates from the pleural margin, if you were to get in there, you can't get it to reinflate. So you're not just having an empyema, you're gonna whatever the indication or the reason for empyema was. I'm assuming it wasn't some bronchopleural fistula from radiotherapy, but if you get into stuff like that, you are getting into some very complicated stuff. We'll just say they got an effusion, they were radiated, and somehow they get an empyema after. So the issue for an empyema is, of course, you like to drain it, and then you said when you drain it, you're not going to get full expansion. So now you're looking at some kind of surgical solution to solve the problem. Now, if your lung is compliant and it was a peripheral lesion that was radiated, I think you do the decort and you get full expansion and the standard way we treat an empyema. The real issue is if you, for some reason or another, have compliance loss and it was a large lesion and there's a lot of radiation traction and now the lobe and the lung doesn't fill the thorax anymore, and you have an empyema. So you don't have a lot of options because your decort in there is still going to leave you with a space, and you're probably going to have an air leak from the decort. So now you got space, decort, and lung that is non-compliant. Now, if you are going to operate on that person, that is what you should expect, that you're going to have a space post-operatively. So if there is an operation in that person, your operation better be some way to control the space. Okay. And this gets to the person who has the chronic air leak after a lung operation. And you put tubes in and you try to sort that out. And eventually they get an empyema from that. And now you have an air leak, you have an empyema, and you've done a lung operation, you've done a lobectomy. Let's say it's a post-lobectomy. So you have a space problem. So it's kind of the similar type of scenario that I would envisioned. So in these kinds of operations where there is an obligate space that you are expecting and you have infection, that infection is never going to get rooted out of there until you completely control the space. So that's the window. That a window controls the space as long as you have pleurodesis of the remaining parenchyma to the chest wall, up until the base of, from the base of the lung up, but the rest of the lung and let's say it was a lower lobe, something or other, and the upper two lobes are fused, and a window would be not a terribly unreasonable problem for an empyema. If you don't have pleurodesis, though, and you do a window, the whole lung collapses. So you can't really do a window without having pleurodesis. So let's say you're going to do an operation, though, and we'll give you this scenario where I'll give you the scenario where you have something that is reduced compliance. Well, radiation is one, but it's certainly a lung resection is another. It didn't reduce compliance, it reduces the size of the lung. And you got a thorax that is bigger than the lung now, and you got close space infection. So that operation, if you're going to do it, you're not there to really just take care of the infection, drain it, whatever. That's not going to solve the problem. You have to come up with some kind of space control. So that's where all of your surgical training needs to be brought up centrally, right to the front of your brain. And that means the full window, the full tent. A tent needs to be done to control the space apically. And, sometimes you can do, we have a procedure here where, the pleura, where you drop down from the apex, you call it a tent. Well, the pleura from the mid-chest down to the diaphragm, we call the rug. So you can elevate the hemidiaphragm potentially. You don't have to resuspend it. That's kind of a historic operation. You can elevate that by dropping the lower part of the pleura, bowstring it straight across the dome of the diaphragm, and you get a pleural rug. So you can do that. You have to inject the diaphragm. Inject the phrenic. That'll also help bring up the diaphragm. Pneumocaths come into play for us, where you put some kind of small 16 or 20 French chest tube underneath. Let's say it's the right side, underneath the right hemidiaphragm, and you fill that. Assuming you have diaphragmatic compliance, your decord, hopefully you freed up your diaphragm, and you fill that abdomen on that side with 1,500 cc's of air, and you keep pushing air in there. Because the issue on these infections, or if there's infection with air leak, is that you have to get space control. And if you do not, you're not going to solve the problem. Now, sometimes some of the goal is just to get pleurodesis of the apical part of the lung so that you can do the window. If you have for some reason you can't get the full lung, you got a chronic leak, bronchial fistula, something like that, where you simply can't get the full lung to inflate to fill the cavity. You need to get apical pleurodesis so you can do a window. And those people, they still aerate the remaining lung because the diaphragm function on the other side. But if your lung is not fused to the pleura, that lung will collapse. You cannot do a window on that person. They will gasp for air. Actually, it becomes a sucking chest wound, and you're packing it with whatever. The whole lung is collapsed, and so it's basically a functional pneumonectomy for someone like that if their lung doesn't fully inflate and isn't adherent to the chest wall. So a window isn't really an option unless there are certain circumstances that are present in the operation. So I think that's when you think about a case like that and you're trying to get an infection out, you really have to think about space control in the thorax. Thoracoplasty comes into play as well. It is a historic operation, but if you have really thickened pleura, you can peel it off the endothoracic fascia, and we have put in gobs of Nunit and Surgisil as a biologic plombage. I think we've done that on a rare occasion to really compress the lung so that you can get better space control.
At what point do you get your plastic surgeons involved for a potential flap?
Yeah,
I know it's hard with the infection.
So most of us are minimally invasive for most of our lung operations. So the latissimus is always present. That's always a good something or other. The problem with the latissimus is that most of these problems are near the base. So let's say maybe if it's an upper lobe problem, I guess that's a more unusual. The empyema by gravity is usually down lower. So, I guess it depends on if you were doing it with BPF or something else. But let's just give you the empyema with real big space. So latissimus is a really fairly superficial chest wall muscle, right? So you lose a lot of length. It's if you're going to take it off its insertion up high in the humerus in that area, and you're going to rotate the base of it off, you take it off the pelvis and rotate it off the midline raphe and take it off the spine. You lose some distance on it, but it's still a great flap. Some plastic surgeons will take it off high up and keep it on its perforators on the spine and use it that way. That's reasonable. Serratus is way too high and it's just not long enough. Omentum is a very, very good option for many things. You've got to make a hole in the diaphragm or some kind of hole subxiphoid to squeak the omentum in, and then you risk the remote chance of hernia because the stomach, I guess, occasionally can follow it. But more importantly, you run the risk of choking off the vascularity. If it's all pedicled on the gastroepiploic, you got to make sure you have enough wiggle room so that you're not compressing the venous return out the right gastroepiploic vein and venous pedicle. You have the artery coming in. That's usually not the issue. It's usually venous. But you can either do it as a subxiphoid or make a small anterior aperture in the right hemidiaphragm on the right side or the left hemidiaphragm. Just don't get schizophrenic. You have to know that is in play. If it's still working, you don't want to bugger it up. So that's where I think that would be. I like the omentum for these things. It just seems like it's a little bit more sticky. If that's possible, I would prefer that personally over muscular flaps if you need to fill the space for some reason or another.
Yeah, there's a lot of options, and it's not an easy situation when you do have that happen, unfortunately.
Yeah, I think the take-home lesson is that if you have closed space infection and volume loss that you cannot recover from a decort, that is the issue here. I think that hopefully was the nature of your question, that you have volume loss for one reason or another, whether it's, in your case, radiation therapy, but in many cases, it's after a lung came out, or a segment of lung, rather. So empyema, volume loss, you got to come up with strategies to fill the space as part of the treatment of the closed space infection.
Let's change the scenario now. Let's go in the operating room. Let's say you do a lot of robotic surgery. You're done tons out there. Now with all this neoadjuvant chemo IO, let's say you're sitting there and that N1 node is really difficult to get out. You're trying hard. You're using all the techniques that it's really difficult, and you're worried about the bronchus now, that you might get into it, or that after you get it out, you might not be able to actually staple, or you're worried about leaving a positive node potentially. What's your thought process, and what do you do next?
Yeah, so there's a lot to unwrap that we don't know. The common sense thing is that you want to get out all nodes that were positive from before. You don't know if they're positive now. Do you fall back to pneumonectomy? That's a famous question. You do a lobe with a positive N1 node, and is the next fallback pneumonectomy? We're shying away from that. We're starting to leave segments, leaving a segment B with a positive N1 node, and you sit pat with the segmentectomy. I mean, there's emerging data that suggests that if knowing your N1 node is positive and doing a segmentectomy, you're just as good as if you would have done the lobe, assuming everything else, the recovery, et cetera, was okay. But I would say this, listening to that scenario, if you are concerned about completing the conduct of a planned operation, okay, and your operation was to take the primary tumor out, skeletonize your lymphatic drainage basins, whether they are subcarinal, whether they are paratracheal stripes, whether they are inferior pulmonary ligament, or whether they are in the hilum, and you cannot do that operation given the way you are doing it, well, then one of the clear issues is whether you should change the way you are doing that. And is that an indication for someone who is struggling in that scenario to open the case? Or if you're skilled enough with a minimally invasive platform, you get main PA control so that you could potentially cut the PA if you needed it. You get, pulmonary venous control potentially if you want to do complete vascular exclusion. But you get main PA with Robnells or whatever people use. I usually use vessel loops and with and kind of tourniquet stuff and pull it out through the chest wall on a minimally invasive robotic or whatever. That's how I do it. But people will get bulldogs and there's a lot of different ways to do this. That then comes front and center. If you cannot complete the conduct of the operation that you are planning, and if it is because of the technology you are using, I think there's a real indication to change what you're doing. And in that operation, doing it open. It's not a sign of weakness, honestly. It is the circumstances dictated. First and foremost, you want to do a safe operation. And having been there, and I can see this scenario, you get the immunotherapy, or even when we used to do chemoradiotherapy, you get a lot of desmoplasia. You get a lot of things sticking to other things. And, one of the things about these minimally invasive platforms is that it's just harder to recover from serious injury to major vascular structures. So risk mitigation is a big deal. And getting proximal PA control, if that's what it takes, that's what it takes. If you're open, it is easier, no matter what anyone says, it's easier to get early control. You can throw a sponge stick on and, your chest is open and you can get a clamp around the main PE, whatever. It's just faster and easier. But if you're in a minimally invasive platform, that's maybe a little easier, I think, because you do have an access incision, depending on where your target injury is. I think it might be a little easier. You get a sponge stick at least to settle your nerves and do what you're going to do. So that's what's on the backside of this. If you persist trying to get out something that, for one reason or another, isn't coming out. So I think that's first and foremost in that scenario, is to think about safety of the operation. Okay, so safety of operation. Now, the other thing that comes up is, again, gets to, okay, you have a positive end node, or you don't know it's positive. I guess, does it really matter? But if you checked it and it was positive, and somehow you did a frozen, it's positive, and you can't get it out, and you think that is an important component of the operation, I think you have to change the operation to get it out. Now, whether you really needed to, that's a totally different question. I don't know what our recent data would suggest. There are people who would argue on both sides of that, I suspect. But going back to the initial goal of your specific operation, and if it was to skeletonize all the lymph node disease out of there that you thought was positive, to get a negative margin on the parenchyma and the vascular and the bronchus, and you cannot complete the operation as intended, that's a problem to sit pat with what you're doing. I don't think you can leave with having done a lesser operation simply because it wasn't easy to do the way you were doing it. If that answers your question.
Yeah, no, it's converting to open is never a sign of weakness, as you mentioned, but it can be hard. It's like, do you do that, and would that change your operation? Sometimes you might not know. You might still be in that situation, even if you converted, but it might be easier to move forward, is what I gathered from what you're saying.
I think the mindset of converting to open is not that you lost the battle. It is that your circumstances dictated that you needed a slightly different approach. And maybe, again, that's some experience and some judgment and some expertise that comes with experience and all of that stuff. But there is never should be never any shame to converting to open. If you look at these folks, whether you did a minimally invasive lung resection or a thoracotomy, and you look at them a year down the road, um, their functional status is often identical, superimposable. If you've done the same operation, right upper lobe with a VATS or right upper lobe thoracotomy, a year later, assuming the same other recovery, et cetera, their how they feel pain syndromes is very, very similar. Now, there is some subtle stuff about the stress and from a thoracotomy pain. Could it suppress the immune system? People are always nervous about thoracotomy having worse long-term cancer outcomes than minimally invasive. I'm not really aware of any data that shows that. If you look at some big database studies, and we have done that, you can't easily find that to be the case. There are some inflammatory markers and other benchtop studies which would suggest that there's more of an acute inflammation and maybe immunosuppression with maybe thoracotomy, but I'm not sure that's the kind of thing you should be thinking about in a scenario like that. You want to give someone a safe operation that fits the intended goal of your operation.
I think that's great. And now, lastly, this is the last thing I want to bring up and talk to you about is when you do convert, especially in the emergent situation that you have a PA bleed, you're robotic or VATS. In your case, robotic. What is your steps? How do you do that to get to a safe kind of open thoracotomy, sponge stick, etc.?
Yeah. So I think of VATS is easier. So I would exclude VATS from, it's really, it's the stress level. There's always stress getting into a PA, but the stress level when you have an aperture that can take a sponge stick straight away or even a cross clamp, I think is lower. So let's just look at a robotic. I think it seems like trends are favoring that operation, certainly replacing thoracotomy and becoming maybe in the next 5 years the dominant minimally invasive operation, but we'll see. So let's say you're in a robotic, and most of the time in our robotic procedure, certainly the ones that I do, I usually have a couple of gauze cigars lying around. I usually actually have 3. Now, I know some of my good friends have 0 because they don't want to lose them and whatever, but I have 3 in there in different places in the chest. And I always have them ready when I'm, try to have them ready in one of my working arms when I'm stapling a PA or even a pulmonary vein. I will have something ready. So on the odd chance there's a avulsion injury or a tear of that branch below the staple line because of somehow some torque or something like that, I will have that on there. Now, you don't necessarily need that because if you have a big PA or a regional PA injury, you can also shove lung over the top in a emergency situation. You have other ports, you shove your lung on there. So the key thing on any of these injuries is to get direct pressure with a gauze. Okay, and you have to check yourself. You can push so hard you can extend the injury. There is some deep breathing. Try to quiet your mind. Try to restore some element of logical thinking, which is all of that stuff. If any of you have experienced these things, and hopefully you don't experience it more than a few times in your career, but that stuff exits through the first window, the initial sight of dark blood coming out from what used to be a injury. So yeah, that's natural, and that's just what we deal with, and that's why we are who we are, because hopefully we get these situations that we can deal with. So getting some kind of transient compression over that area is the first thing that you need to do. Some of these injuries look a lot worse than they might be. I will tell you that. Some of them that I thought were, oh my gosh, look at this, but you pack it, you hold pressure, and there was some small rent in a relatively small PA branch that was just below, maybe you were dissecting it or something, and it was some subtle avulsion, partial, not the whole thing. and there's been some fibrin, there's whatever, you've got some transient feel on that. Now, it's almost certainly not something you can forget about, because it's going to happen again when you twist the lung and you're going on with your operation. So, but many of these injuries aren't quite as extreme as you would have initially thought. So, hold pressure there. The real issue that comes up is if you are unable to quickly control the bleed, because you've only got about 15 or 20 seconds max. Because suddenly, then, if you have a big bleeder, the amount of blood that is welling up is going to preclude you from being able to control the spot, because you can't see it anymore. So you have that period of it happening and being ready to control it needs to occur very quickly. Now, occasionally with your Cartier on a robot, you can gently grasp the area. If you have a bleed, knowing that is an inherently unstable situation, because you're going to have to dedock the robot. So ideally, in a bleed from the PA, it's your assistant who's coming in through whatever. If you're a 4-port technique, you have a 5th assistant port, and whatever that 12-millimeter port, where you're passing gauze sponges and suction, it's that assistant that is holding your gauze cigar over the PA, just so you can dedock the robot and get it out of the way. And your team should be pretty well versed in rapid conversion, and it's always nice every so often to have someone at the beginning of a case, have your team dock the robot and quickly dedock it and move, just as a refresher every 4 months or so. They all know how to do this. The new platform, whether you're at the XI or the new D5, very quick to. It's not like the old SI. Very quick to dedock and very quick to move out. So I think you have to have some rehearsal for these things. But if you do get a PA bleed and you can control it, I think that changes the algorithm. Okay, so I think there's an algorithm where bleeding controlled, bleeding not controlled, and that needs to be that appreciation needs to happen in about 15 seconds, because not controlled means slash thoracotomy, no bovie, essentially, and a lot of chest wall bleeding on your way out. But that means sponge stick on the way in and really suction. And at the same time, your whole team needs to know, not just your surgical team, but the whole operative team in the room needs to know PA bleed, blood in the room, let's go. And if you think that you are losing that much blood early, then they need to start transfusing right away. So if you have control, blood, set up blood, we need a couple of units. You don't lose control. You have time to settle everyone else in the operating room out. Everyone gets settled out. Okay, let's get anesthesia. We got to make sure, do we need a different IV access? What kind of location? Do we have anything else? Do we have good IVs, et cetera, et cetera? What's our best IV, et cetera? So you start to strategize for the worst, which is you're controlled now, but you lose control, and now you have a bad injury in the proximal PA. That on the left side. So you don't have a lot of PA to work with. So I think those kinds of preparing for the next phase of that problem is critical. So the first phase is getting control. Now, if you don't have control, then everyone's going to hear about it all at the same time. Blood in the room, start transfusing. You don't have control. Mm-hmm. So by the time you open the chest in 30 seconds, you got 1.5 liters of blood. I don't know how many, you ejected, 100 cc's in the whatever number of beats it's been. So you're going to have to give volume wide open, but you're going to have to replace it with blood because they're going to get shocked. So that's a big deal. Now, mm-hmm. Once you get the chest opened, if you're in that and you have a really bad injury, then just packing the hilum and with gauze and holding it will usually control things. Sometimes you can get your fingers down there, you can feel. Getting into the pericardium very early is a critical element. So you can certainly on the right and left, you can pinch or get a clamp on the proximal PA. That's the only way to control these things. And if you are still having trouble and you are, you know, you cannot, your PA injury is extending, well, then the only salvage you have is cardiopulmonary bypass. So the groin should be prepped out, and that you can. It's this the injury dictates how far along the treatment plan. It's kind of like someone who has an arrhythmia that fails magnesium and then fails the next thing and then the next thing and then you're onto some extreme treatment for it. Well, that's where these things can go. But for the most part on the robot, unless it was two instruments that were fighting against each other that suddenly become loose, and then the spring of the instrument has lacerated the PA, or every so often you got to be careful about that. But unless it's something like that, most of the injuries are recurring while you are dissecting on something. So you are actually starting to see it happening while it's happening. And one of the key things that you have to remember is to take tension off the tissue. Because on the PA, if you have that fourth arm retracting and you're just doing something else and you start to see a bleed, the putting the gauze on there is going to additionally pressure, because the gauze is probably going to be pushing the other direction. So get arm 4 or whatever your retraction arm is off the tissue so that you're not putting additional tension on the tissue.
Well, that's great insight, and that can be a terrible or horrible situation to be in. But I think what you said in the beginning of that is just kind of taking that deep breath, staying a little calm, can be easier said than done when you're in that situation. Of
Yeah,
course.
it's I don't care who you are, how many operations you've done in your life. This is one of these issues that you are going to be. Everyone is going to be in the same mental situation when something like this happens. It's just it's a very unnerving situation. But having thought about it, what do you do if that were to happen? Kind of rehearsing in your mind, even when it's not happening. If you were talking about that case before about the toughened lymph node and it's stuck over here and maybe it's an airway, but maybe it's on a PA. So when you're trying to dissect that, and if you are trying to stay minimally invasive, you really need to understand, the pressure points of the operation. Okay, what's your plan B if that goes south? What's your plan C if that plan B goes south? These kinds of funny things that pop up. An ounce of prevention, that's a big deal here. And I think it's worth more than just a pound to cure when it comes to vascular injury. So understanding pressure points, understanding where your injury might occur, and understanding your own skill set of how to manage that are all very critical elements. And people who do a lot of vascular reconstructions on the robot, whatever, often have had to get around. I don't know how many people out there get around the left main pulmonary artery intrapericardial on a robot, or around the right main pulmonary artery. For whatever reason, you may have. Not many people do, and so you don't want the first time you do it to have been in a situation like this. That would be a situation where you would open to do it, because it's my rule to the faculty and my residents here. It's very seldom the first mistake that's the problem. It's usually the second. Usually, I think thoracic surgery gives you one. You get one. And to be a really safe and effective surgeon, you don't get the second mistake. You can recover after the first. So that's something to keep in mind, that most of us can recover from the first injury. But if you get an injury going around the main PA because you can't see and you get an injury there, that is, when you're getting around the main PA, you're either intrapericardial or you're really deep. If you're on the right side, your SVC has moved off, and you're in, that injury is usually posterior, and then you're in a world of hurt. So that's a totally different animal than the first injury. which may have been a truncus branch or an ascending branch or something else, which is compared to a posterior proximal PA injury, whether intrapericardial or not, that peripheral injury, that's chump change. So that first injury, first mistake, usually you get a redo, and that redo has to be perfect. You get a do-over, and that needs to be perfect. And so that's where this focused purpose and trying to clear your mind, and now, okay, I got to get around that. Okay, get partners in, all of those things that you hear about, that they need to be, this is where they get put in play. And, you're not the only person that's ever got a PA injury if you get it. I can tell you that from personal experience. Okay, so you're not the first. So don't think that this never happens to anybody. It's people who I'm a Dodger fan. Shohei Ohtani hit 54 home runs, and he struck out 140 times this year. It happens. Sometimes you strike out. Okay, even if you're a great home run hitter. So you gotta just understand that and try to compartmentalize that stress, get that controlled, and then move forward, because everyone in your operating room is going to be somewhat paralyzed, and the one person that really can't be is you. So that's when you get other partners in, and you get other minds in, and other people you trust, and that kind of thing.
Well, this was a great discussion and great conversation. Thanks, Dr. Murthy, for this. And thanks for being part of this podcast. And we're excited for this episode. Thank you again very much.
Appreciate it. Take good care, Harry.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.